So, hello everyone. I'm going to open the session. And first, I'm going to talk a little bit about puberty. What are we talking about? So, puberty is the transition between the juvenile state and adulthood. The most visible changes during puberty are growth in stature and development of secondary sexual characteristics, but equally profound are changes in body composition and the achievement of fertility. To assess the development of secondary sex characteristics, we use the 5 stages described by Marshall and Tanner in 1969. So the first sign of puberty initiation is typically breast development in girls and testicular enlargement in boys. The development of axillary and pubic hair, known as pubarch, is also incorporated in the Tanner stages, but should not be used as a marker of the onset of puberty. Because in both sexes, pubarch is dependent on an increase in adrenal androgen production. That's a physiological event named adrenarche. So here is represented the growth spurt with the increase in growth velocity. As you can see, it's a bit different depending on the age at puberty. In general, when puberty takes place within physiological limits, final height will not be affected. And we can also see that the timing of puberty is different in boys and in girls. So puberty and reproduction are controlled by the hypothalamic pituitary gonadal axis. In human beings, the hypothalamic pituitary gonadal axis is active in mid-gestational fetus, but silent towards ends of gestation. At birth, there is a reactivation of the axis and an increase in gonadotropin concentrations. And these concentrations then gradually decrease toward age 6 months, with the exception of FSH concentrations in girls, which remains raised until age 3 to 4 years. This period of activity of the axis is called mini-puberty. It has been proposed to lay the groundwork for pituitary LH and FSH responses to GnRH during the later reproductive phase of life. But the precise mechanism remains unknown. And after this mini-puberty, then there is an active inhibition of GnRH secretion during childhood. And then puberty is the removal of this inhibition. So puberty is initiated with a sustained increase in pulsatile release of GnRH from the hypothalamus after this quiescent period. This GnRH release stimulates the secretion of LH and FSH from the pituitary gland, and which in turn act on the gonads to promote gametogenesis and the production of sex steroids. And as you can see here, the hypothalamus is the great coordinator of the axis and integrates internal and external signaling factors, such as nutritional status, endocrine disrupting chemicals, and so on. So the reawakening of the GnRH system on puberty is considered to be under the control of a variety of genes that work in coordinated networks operating in the hypothalamus. The precise mechanism that triggered this reawakening remains largely unknown, but the current hypothesis postulates that a loss of transsynaptic inhibition together with a rise in excitatory inputs are responsible for the activation of the GnRH release. The age at puberty onset varies greatly between individuals and, as we already said, between the sexes. Girls on average experience the onset of puberty at younger ages than boys. So puberty is deemed physiological when it begins between the ages of 8 and 13 to 13 and a half years in girls and between 9 and 14 years in boys. And these limits are selected to be 2 SDS below and above the mean age of onset of puberty, as defined by population studies. However, population studies have limitations, and thus so do the age limits used to define normal pubertal timing. It's also interesting to note that the age at onset of puberty has been subject to a secular trend towards an earlier age in girls, between an earlier age at menarche in girls between the mid-19th and the mid-20th century. So that's here. This has been attributed to improved health, nutrition, and sanitation. And interestingly, you can see that age at menarche is still decreasing in some countries, such as emerging countries. Here you can see it's China and India. While age at menarche has been stabilized in our regions since the 60s, age at onset of puberty, meaning breast development in girls, seems to be constantly decreasing, suggesting an effect of environmental factors. This decline in the age at onset of puberty has raised psychosocial concerns and engendered questions about the definition of precocious puberty. But nowadays, precocious puberty is defined by the onset of pubertal signs before 8 years for girls and 9 years for boys, or for girls also menarche before 10 years. So the tools you have to evaluate precocious puberty: first you have to collect the personal and family history. Then you have to run out your clinical examination. The stage of pubertal development should be classified as described by Tanner. And careful assessment is needed in obese girls to avoid overestimating breast development. The concept of clinical progression is essential because in a significant number of cases, pubertal manifestations will regress or stop progressing. Progressive precocious puberty is almost always associated with a high growth velocity. And in fact, a high growth velocity may also precede the onset of pubertal manifestations. For the bone age, a reference atlas can be used to evaluate the effect of sex theories on epiphyseal maturation. And the bone age of patients with precocious puberty is generally greater than their chronological age. Level of sex theories should be determined in the morning with the use of assays that have detection limits adapted to pediatric values. Most boys with precocious puberty have morning plasma testosterone values in the pubertal range, but in girls, serum estradiol levels have a low sensitivity for the diagnosis of precocious puberty. So the gold standard for evaluation is the measurement of gonadotropins after a stimulation test. And LHP greater than 5 to 7 units per liter, it's a good sign of precocious puberty, but there is an overlap between prepubertal and early pubertal phase. You can also do a pelvic ultrasound in girls, and we know that a uterus length more than 34 millimeter or a volume more than 2 milliliter has quite a good sensitivity to diagnose precocious puberty in girls. So as we said before, there is a considerable variation in age of onset of puberty. The hypothalamus integrates a series of endogenous and peripheral environmental signals that lead to the reactivation of pulsatile GnRH secretion. So the timing of puberty is determined by interactions between these genetic and environmental factors. And then the age limit corresponding to precocity can lead to debate according to these factors. About the environment, so our understanding of the molecular mechanisms responsible for the precise timing of puberty has expanded recently, due in part to the recognition of the role of epigenetic mechanisms in the control of normal pubertal maturation. So it's now clearly established that a switch from epigenetic repression to activation within kisspeptine neurons is a core mechanism underlying the initiation of female puberty. But however, little is known about the pathways conveying epigenetic information from different stimuli such as nutrition, circadian activity, environmental toxin to the hypothalamic cell controlling the timing of puberty. About the genetics, we know that the physiological variations of puberty are explained up to 80% by genetic factors. So here, as you can see, 20 studies have indicated that pubertal timing is a highly heritable trait. In girls, we can see there is a stronger correlation with age at menarche between monozygous twins than between dizygous twins or sibling pairs. And despite the fact that there is evidence of this genetic influence, again, the precise underlying mechanisms are still largely unknown. So several approaches have been performed in an attempt to identify potential genetic factors that modulate the hypothalamic pituitary gonadal axis in physiological and pathological conditions. And these 4 mutations in 4 distinct genes have been identified in patients and families with a history of central precocious puberty. It's interesting to note that MKRN3 and DLK1 are maternally imprinted gene. So what is it? A maternally imprinted gene means that only the paternally inherited allele is expressed. So affected persons inherited the mutation from their father. So here is to illustrate the notion of familial central precocious puberty linked to an MKRN3 mutation. And as you can see, there was a family history on the paternal side in 2 families, with the grandmother here and the grandfather here, and only in siblings in 3 other families. Since this publication, that was the first one, various other variants of MKRN3 have been described, making it this mutation, MKRN3 loss of function mutations, the main genetic known cause of central precocious puberty to date. So here's just a quick word. We ourselves at HUDERF identified 6 novel and 2 recently described variants in the MKRN3 gene in 9 girls, 1 boy and their family members. So an MKRN3 loss of function should be considered after careful history pinpointing paternally inherited central precocious puberty. From a clinical point of view, while our patients had important advance of bone age and hypostimulated LH, but no clinical criteria can distinguish them from patients presenting with non-genetic idiopathic central precocious puberty. Here's to illustrate the story of one of our patients, and I think it's a good illustration of precocious puberty in a girl. So she had a positive paternal family history with a paternal grandmother who had her menarche at 8 years. She was 9 years old. She was Tanner stage 4. Her bone age was 3 years older than her chronological age. And her lab results show a sky-high level of peak LH after the stimulation test. And she actually experienced her menarche a few days after the test. So, interestingly, although this patient was untreated, she reached a final height within her target height. And you can see here her growth spurt. That was really a nice one, but really, well, yeah, before the average age. So, precocious puberty. Most of the time, when you have precocious puberty, in fact, you have central precocious puberty. It's caused by early maturation of the hypothalamic pituitary gonadal axis. Most cases are described as idiopathic. Not all, but most. Some or most of these cases might have a genetic, metabolic, or environmental component or combination of these factors. There is sometimes a genetic cause with a positive family history, so it's always interesting to collect family history, and also on the paternal side, in view of the potential involvement of maternal imprinted gene. It's rarely organic, but sometimes it is. That's what we're going to discuss with Cécile. And about peripheral precocious puberty, then sex hormones are usually derived from the gonads or adrenal glands or from exogenous sources without activation of the hypothalamus and pituitary gland. And just to finish with my take-home messages, there's then the importance of early environmental factors, the existence of a secular trend but unchanged definition of criteria or age of puberty. So precocious puberty is standard stage 2 before 8 years in girls or 9 years in boys. You have an increase in growth velocity. You have the important notion of progression. And also the appearance of early pubic or axillary hair is mainly a reflection of adrenal activation and not puberty. Thank you for your attention.